amount of time for the perfect. So we're starting to record. Hello everybody. My name is Ian Cronish. Many of you know me. I'm the director of the Columbia Roybal Center for Fearless Behavior Change, one of, I think, 11 Roybal centers around the country that's funded by the NIA. We also may have some people joining us that found out about this presentation through the Science of Behavior Change initiative, where Columbia is the coordinating center, and we welcome all those attendees that heard about this seminar through SOBC. Today, it's with great pleasure that introduce our guest speaker. This is Yoni Ashar. He completed his doctorate in clinical psychology and neuroscience from the University of Colorado at Boulder under the mentorship of Sona Dimidjian and Tor Weill. And currently he's a postdoctoral associate at Weill Cornell Medical College, our sort of sister institution. And today he's going to speak to us about a hot off the press clinical trial that was just published in JAMA Psychiatry. And I'm really excited for him to tell us about his mechanism inspired research. So go ahead, Yoni.
Great. Thanks so much, Ian, for inviting me. It's great to be here. And I invite people to, whoops, that's the wrong button. Just to jump in and share their thoughts. There'll be one point in particular. I'll pause for that. And I am aiming to finish in about 40 minutes or so to leave plenty of time for discussion. I'd really value that and hear people's thoughts. So I was very inspired by the name of Ian's, of the center here, Center for Fearless Behavior Change. I wanted to work that idea of fearlessness into the title. So that was the best I could do. But I think that's at the heart of this treatment I'll be telling you about, pain reprocessing therapy, fearlessness in two ways. And I'll come back to that. So I'm a consultant with United Health Group and with Lynn Health, and I'm also a clinical trainer with Mental Health Partners of Boulder County and with the Pain Reprocessing Therapy Center. So chronic pain is one of the leading causes of disability. It's back pain takes the #1 slot, and it's also strongly represented in positions 3 and 4. The economic cost is huge, more than heart disease and cancer combined, 650 billion in recent estimates. And it's also responsible for approximately 300 billion in low value care, to guideline discordant imaging and procedures, and what some people describe as medical waste. Despite all this, the prevalence of chronic pain is increasing. This is not being driven by an aging population because we see this increasing pain across all the age groups. So I think anyone surveying these data would agree that the state of affairs is dismal, right? Huge cause of disability, huge amount of resources we're throwing at it, and the prevalence is only increasing. And on the patient side of this, our patients tell us, I've tried everything, nothing's working. The doctors can't find anything wrong. The doctors think I'm making it up, contributing to a tremendous amount of suffering and often decades lived in pain for many people. So what's going on here, and what I'd like to submit is that one factor that's responsible for this is that there's been a big focus on peripheral factors in how we conceptualize and how we treat chronic pain. And the data show that these peripheral factors are actually only weakly related to pain. So imaging findings of the periphery are highly prevalent in asymptomatic populations. So 87% of pain-free necks have bulging discs. 72% of pain-free shoulders have superior labral tears. Let me just turn on my flaming cursor so I can do this. Disc degeneration is, by the time you're in your 80s, whether you have pain or not, you have very high likelihood of having pain. And at the same time, if we turn to treatments that target the periphery, they're often no better than sham. So this is a meta-analysis of chronic pain patients over 15 trials, 1,500 patients. And there was no statistically significant difference between real and sham surgery. So in these trials, people receive, in the sham group, people receive some kind of superficial incision, and they know there's a 50% chance they got the real surgery or the sham, and they can't tell when the blind is assessed, which is not often enough. But there's a small superiority of real surgery, but it's not statistically significant. And at the same time, although these peripheral factors do not seem to correlate strongly with symptoms, we know that there are a host of changes across the nervous system that accompany chronic pain. These range from the sensitization in peripheral nociceptors, as well as inflammation in the periphery, to sensitization in the spinal cord. Particularly changes in dynamic wide range neurons have been implicated in the spatial spreading of pain, and a number of changes in the brain that accompany chronic pain as well. And to give just a brief summary of some of the key brain regions and findings, we find that chronic pain is associated with heightened brain responses to aversive stimuli, reduced prefrontal inhibition of pain, increased functional connectivity using a functional MRI in the default mode network, somatosensory cortex, the insula, thalamic dysrhythmia, reduced dopamine signaling, which has been linked in particular to anhedonia and low motivation in chronic pain, neuroinflammation, and more. And the view is that many of these processes, or these processes, may be responsible for the persistence of pain, rather than pain being primarily driven by peripheral problems. At the psychological level, we have started to rethink pain, whereas we might have initially thought of pain as a one-to-one map signal of noxious input. Pain is now viewed as a signal providing predictive control. So pain has a function. Pain functions to guide behavior. And to do that, pain has to predict what's happening next. And so as an organism or a person is navigating the world, if a certain action is predicted to be dangerous, the brain might create pain in a predictive fashion to guide behavior away from that. And that opens up a range of possibilities in terms of particularly the predictions being off. Mathematically, this has been formalized in Bayesian models, where you have top-down priors or expectations about how painful you expect something to be. To take a clinical example, let's say a person with back pain who experiences pain when they bend over. So they will expect to have pain when they bend over. And that's visualized here in this distribution. And then there's bottom-up signals coming from afferent signaling from the body, which is then integrated in the experience of pain. And critically, if the expectations are too strong or the variance around these expectations are too low, they can exert a strong pull on the pain experience so that the pain experience is relatively insensitive to peripheral input from the body. In the clinical world, a model that's had a lot of influence is the fear avoidance model of pain. And at the heart of this model is the appraisal of threat. So when pain is appraised as threatening, that drives priority to pain control, fear, avoidance, interference, negative affect, which then cycles and reinforces the pain. Whereas when the pain is appraised as low threat, it drives positive affect, approach behavior, and recovery. And to just put a point on it, one view is that after an injury, say you're moving your houses and you bend over and you strain your back, there is so immediately after the injury, there is some factor, some peripheral processes that are driving the pain. But as time elapses, the injury resolves, because the general rule is that injuries resolve with time in general, but the symptoms persist. And at that point, they're driven more by mind-brain processes. So in this way, it's like a bit of an analog to PTSD, mechanistically, in that there is a trauma. The trauma resolves, the person has been removed from the threatening context, but due to fear and avoidance, the symptoms are persisting. And I want to share a clip from a patient in our study that I'll be telling you about that just illustrates this point so beautifully. And I'll be sharing a few patient clips today, and they are all patients have all consented for these to be shared. And so this patient just really articulates this beautifully.
Everyone just continued to reaffirm for so long that I'm broken, you know, like, you've got a problem. You've got a problem. And my neurosurgeon literally told me, like, I'll be in pain the rest of my life. And it's just about managing it as well as we can. So I believe that. And I think I just have settled with the fact that I'm going to be in pain for my whole life.
So we, hear in her words, why, anyone would have a lot of fear around the pain, given messages that, you've got a problem, you'll be in pain the rest of your life, and a lot of, predictions about the future course of symptoms. Yeah. So a critical point I'd like to make here is that not all chronic pain is alike. And this is being well recognized in the ICD-11, which is coming out soon, which is for the first time introducing this distinction between primary and secondary pain. And secondary pain is pain that's secondary to some medical, physical problem in the body, some kind of disease state. And the pain is secondary to that, it's the result of that. Whereas primary pain, the pain is conceptualized to be the problem itself, that's not secondary to anything else. The pain is the problem in its own right. Another common distinction that's being used in the literature is between nociplastic, nociceptive, and neuropathic pain. These are mouthfuls, but nociplastic is, in my view, functionally equivalent to primary pain, where it's plasticity in brain circuits that are believed to be the primary driver of pain. And so these are dichotomous distinctions that are categorical distinctions, but really it's a spectrum. So a person's pain would be, a particular patient is likely to fall somewhere along the spectrum from peripheral injury, processes that are contributing to the pain, versus central nervous system contributions. And the idea is that, after an injury, the contributions to pain can shift from peripheral factors to central nervous system factors. So, in cases when chronic pain is driven by fear and avoidance and maladaptive priors, this raises a natural question of whether it can be resolved by psychological treatment. And I want to pause here and invite people to just react to this and let me know what they're thinking about whether it seems reasonable or possible for pain to be resolved by psychological treatment in these cases. So there's a chat. Taylor's giving me a thumbs up. Okay.
Yoni, Joe Schwartz, it seems to me that while it might be, psychological treatment might well be helpful, that there's a danger that I've heard from many people that that you're then telling them the pain is all in their head, and that it's not real, and people with chronic fatigue syndrome or fibromyalgia really don't like to hear that.
Yeah. So what I hear you saying, Joe, is this message has a high risk of being invalidating. Like, maybe this is all true, but how can you actually ever tell this to a patient? Because they'll shout at you, they'll kick you out, they'll throw you away, right? This is like the most offensive, invalidating thing. That is a very real concern. And yeah, and Elizabeth is seconding that with this kind of stigma and dismissive thing. And that's a major problem. So now we're in this kind of double bind where potentially you don't give this message to people, but people get like the video I showed, where people don't have a clear understanding of what's possible, what's causing the pain, will there be pain, is there something wrong in their body. On the other hand, if you give this message, it could be very invalidating. I'd like to believe that we have some ideas about how to package this message, that's the way that's acceptable. And we should talk about that at the end, about how to get this over. I'll say in our experience, most people are either receptive or delighted to get this message. Now, when given the right way, it's actually a tremendous relief.
And the other thing I was going to just that I observed is what's provocative is the word resolved there. Most of us would think,
yes,
really
thank you
ambitious,
for pointing out that.
but I know you probably put that there for a reason. So
I put that there for a reason. That's what's really provocative to me, this idea of resolving chronic pain. And yet, when I think of something like panic disorder or PTSD, I think we'd all agree it's possible for it to be resolved by psychological treatment. Maybe the rates aren't as high as we would like, especially for PTSD, but it's certainly possible that for some people you could have a full or near full resolution of symptoms with psychological treatment. And so what about pain? You know, could the same work for pain? But
Can I add that? Can I add something about Sona, who was a physician back in the 90s, who wrote a book? And if you hear the testaments on 2020, and you know, just by changing the way of thinking about their pain, he proved it. But his work hasn't been publicized that much.
Yes, is that Nancy? No, I don't. Yeah.
Sorry, I'm Nancy Chang.
Nancy Chang. Yeah. Yeah. So the names aren't popping up. Thanks, Nancy, for raising that. Yeah, Sarno is great. He's a controversial figure to some. He never did any studies, but there, you know, the testimonials are like overwhelming. There's a website where you can see like literally hundreds of testimonials of people saying that this guy cured my pain by talk therapy. Unfortunately, he never ran a study. So this you know what Ian pointed to is exactly right. I think what I'm trying to be provocative about here is this idea of can you resolve it, and that's exactly the kind of question. Which to me, you know, if everything we're saying is true, well, why can't it be resolved at least in some patients with this kind of treatment approach? So let's look at what's happening right now. So leading psychological treatments have small effects on pain intensity at post-treatment. So CBT, there's been 59 trials, really quite a lot, over 3,000 patients. And effects on pain intensity versus active control are small. And even versus treatment as usual, effects are conventionally considered the small range. As same acceptance and commitment therapy, much less research, but meta-analyses have reported, or at least different meta-analyses find different things, but this Cochrane review found no significant effects in pain intensity and very high heterogeneity between studies as well. So if we think it can be resolved by psychological treatments potentially, then why are these treatments not having nearly this sort of effect? And let's take a little bit of a closer look at one of these. This is just one example. I hate to pick on anyone in particular. I actually am a big fan of ACT for Pain in many ways, but this is just a great quote that I could highlight here. So this is a self-help workbook for chronic pain. Pain is usually an important message from the body, alerting the brain that something's wrong and needs attention. This book will target the suffering caused by your pain, not the pain itself. So two things to really focus on here is the clear messaging that you've got a problem, right? There's likely something wrong with your body, and that's contributing to your pain, and that we're not going to even try to target the pain. That's not the goal. What we're trying to do is help you live more gracefully with the pain, to have a more rich and full life, higher functioning, less disability. Now, this is beautiful for secondary pain. If there's some medical condition that's driving the pain, yes, there is something wrong. And yes, let's live more gracefully for that. But what if it's truly neuroplastic pain that's driven by fear and avoidance? Maybe there's nothing wrong, and maybe we could actually target the core symptoms themselves, like we do with panic disorder. So as I was just saying, these leading treatments aim to reduce suffering, disability, not pain, and they present these peripheral problems as potential contributors to the pain. So can we do better? Can we resolve many cases of chronic pain? So now I will tell you about our study. I'm just checking the time. We recruited 151 chronic back pain patients. We targeted primary CBP. or I should maybe more accurate to say, we aim to have a sample enriched for primary CBP. So we excluded people with leg pain worse than back pain, because that can be an indicator of radiculopathy. We excluded cancer histories, symptoms of cauda equina, and a couple other factors like this, aiming to have a sample enriched for primary pain. But no forms of like a disc degeneration or stenosis or any of those factors were excluded, because those are often not related to pain, as I showed earlier. We required back pain intensity greater than 4 out of 10. One thing I just want to make clear here is that people were not dropped from the study once they were enrolled. If they were found to have a diagnosis other than primary pain, they were not excluded. And if that's not clear right now, I hope it will become clear soon. So let me tell you a bit about our patients. The mean age was 41, slightly more female than male, an average of 10 years of back pain duration. And now the mean disability was 23 out of 100. This is in the moderate range, is to the low end of the moderate range. It's important to be clear, this is a relatively low disability population relative to some samples. And just to give like one other snapshot of these patients, they were highly educated. So we ran the study in the Boulder, Colorado area. There was clearly no inclusion criteria around education level, but the sample that we enrolled, everyone had at least some college education by self-selection factors and other study context factors. So patients completed a pre-randomization functional MRI scan, blood draw to look at inflammatory markers, and a battery of patient-reported outcomes. They were randomized to one of 3 groups: a usual care group, where they were asked to just continue whatever they were already doing in their pain care routine, whether it was working with a physical therapist, whether it was doing ice baths or hot pads. A placebo procedure. This was an open label placebo injection. Patients were, so in the open label placebo, both the patient and the provider know that the placebo is inert, and they're provided education that can be effective anyways. This has been shown to be as effective as deceptive traditional placebo treatments in some studies, when the right study context, when the right context, treatment context is provided, like education and a warm, caring provider, letting people know that this can automatically trigger your body's natural healing responses, even if you know it to be a placebo. I'm not going to be talking too much about this, but I'll be glad to more in the Q&A. And then pain reprocessing therapy, and then people returned after a month. The treatment period is about a month, and they returned later for an identical assessment battery. So pain reprocessing therapy was developed by Alan Gordon, and as well as Howard Trubiner. And in this study, patients had one telehealth session with a physician that was aiming primarily to diagnose and assess the causes of pain, peripheral versus centralized contributions, and to provide education about the pain. And this is this key message that Joe and others were raising earlier about how do you give this message. And then 8 psychotherapy sessions as well, over 1 month. And so the key elements of pain reprocessing therapy, PRT, are to assess the centralized contributions, the centralized and the peripheral structural contributions to pain, and to provide this education that the pain is neuroplastic and reversible. So key points to hit here. 1, the pain is 100% real. You have to hit that strong and early to get around to help with some of the issues that were raised earlier, right? The pain is real. We know the pain is real. What we're trying to figure out is what's causing the pain. And if it's due to the brain, this is good news. This is really good news. You don't need any surgeries. You don't need any addictive drugs. These brain processes are modifiable. They're reversible. We have a treatment that we think can really help. And providing a lot of education, similar to some of the background I provided here about changes in the brain and chronic pain, and how we've learned about the neuroscience of pain, that changes in the brain can cause symptoms to persist after injuries have healed. And I'll tell you anecdotally, in clinical practice and in some feedback from the study patients, many people are really delighted to hear this. They feel like for the first time they have an explanation that makes sense. they've received, 10 different explanations from 10 different providers, none of which really held water. Is it the abs are too weak, or the disc is degenerating, or it's, this tendon is too tight, and none of that kind of makes as much sense to them as these brain changes. One thing that also seems to help get this message across in a way that it lands and is accepted is talking about the brain. They're saying, your brain has learned this, or the brain has learned this, and not focusing on the mind, and definitely not focusing too much on stress or emotion on this early phase, because that can be a very sensitive thing to say. It's stress, or it's repressed anger, or something like that. So we don't provide that. It's just kind of your brain. The brain is smart. The brain learns. When it's been in pain for a long time, the brain gets really good at it. It's like learning to play guitar, but unfortunately, it's learning to play pain. Okay. And then a series of exposure and reappraisal techniques. This is learning to reappraise the sensations as safe, using mindfulness and positive affect induction. I'll show an example of this on the next slide. And doing this during feared activities. So the aim here is fearlessness of the pain, trying to really be fearless of the pain, reminding yourself this is safe. The most common metaphor is a false alarm. The pain's a danger signal, the alarm's going off, but there really is no danger, there's no threat. And then also processing threatening emotions and stress as needed as well. And that's this second aspect of fearlessness that I was trying to hint to in my title slide, that there's fearlessness of the pain, and there's also a general sense of feeling safe that the PRT aims to promote, a general way of feeling safe. And there can be emotions that are present that make us feel unsafe. There can be difficult relationships, there can be hostile environments, and anything that can help a person feel safe is recommended in PRT. All right, here's a little clip to just to give people a feel of what this looks like and how it's, for anyone who's familiar with CBT or ACT or other pain treatments, how it has a different flavor. Sorry, I have to flip through that.
So Felicia, I just want you to turn your head 20 degrees, 0, 20 degrees, and feel the pain. Let the pain come. But it doesn't matter if the pain comes, because we know that there's nothing wrong with your neck. We don't care about stamping the pain out. All we care about is reframing your understanding of what's actually happening. Your neck is sending the sensations to your brain, and your brain is going, ah, and that's all that the pain is. But this pain is safe. As you keep going like that with your neck, it's just a nice, gentle stretch.
So this was not a patient in the study, I forgot to say. It's a live demo during a training, but it's just a great short clip to give a flavor of what you see here of engaging in the feared activity. For this patient, it's turning the head, which has been painful, conditioned, classical condition, associated with pain in the past, reappraising it as safe, using mindfulness and this education piece. There's nothing wrong with the neck. I'll pause for a moment. I think my next slide is the study results, and to see, if anyone wants to jump in and say anything or any reactions at the moment. But no pressure. Glad to wait till the end.
You only had a couple questions, if that's okay.
Yes, please.
The first was, can you just talk about how the study was advertised? Were these people who sort of saw a flyer somewhere and they proactively reached out to you, or did a pain, the doctor or somebody identify patient-centered practice?
Yeah. Thanks so much for asking. This was recruited from the community. A major source, so we had flyers up in doctors' offices. A major source of referral was one Facebook advertisement, advertising for a mind-body treatment for chronic pain. And we were kind of a funny fluke, but we were lucky enough to have a local newspaper run a feature story about the study that was happening, and a lot of people read the newspaper and article and approached us. So we had a big rush of recruitment in that 1 week after the article came out. So it's a community sample is how about it.
But it's sort of pitched as like a mind-body intervention if they sort of saw the title of the study.
Yes, exactly, which is also important in terms of who would respond to that and who would be interested in that. So there's some kind of self-selection that's happening in that recruitment process. Yeah.
And the other question, this has come up in, we've thought about some of these ideas in the context of someone maybe had a cardiovascular event and we want to help overcome their fear of exercising. Because they may feel being out of breath or a twinge in their chest, and they may fear that that's a harbinger of something serious going on. And, a little bit different in musculoskeletal, but how did you address still what if you were wrong? What if they really had something that was misdiagnosed? How did you guys handle that aspect of it?
Can you take a message? I'll phone her back.
Okay, no problem.
Thanks.
Yeah, we had a 1 hour assessment with each patient. That was a relatively in-depth assessment. And of the 44 patients who completed the assessment in the PRT group, first everyone continued to the study, and 42 of those were found to be primary pain. The two that weren't, that was kind of unclear, we didn't give those strong messages. So I would say we only gave those messages when we were really pretty confident, our clinical team had done the assessment and found it to be primary pain. But if it's not as clear, you don't want to give that message in the same way. Now, that being said, it's really rare and unusual for one of these activities to be considered dangerous, like neck turning or bending over. These are the activities we're encouraging. We're all kind of normal and safe. And I think almost every chronic pain clinician, whether they agree with me on everything I'm saying or not, would say that, yeah, these aren't dangerous things to do. Like, even if you have a degenerating disc, to bend over isn't going to really make it worse or something. You might have a pain flare up, but it's not going to worsen any underlying condition. Yeah. And I just think the way you described that, Ian, of someone with cardiological condition, and then they start exercising again, and they have a sensation, and they interpret that sensation as threatening, and they stop exercising. That's a perfect, just parallel to how we're thinking about it here. So someone with neck pain would turn their head a bit, feel some pain, I shouldn't do that, and they would stop turning their head, and that would contribute to this fear avoidance cycle. Courtney, to your question, yeah, I think it's both. I think that combination is powerful to do that together. This combination of doing exposure while reappraisal is a powerful combination that we think is helpful. Future studies could try to tease apart the different pieces of it.
This is Ian following up from before. That question about how do you know for sure, is that something that the therapist, is that something that patients said often as well, or wasn't as or patients kind of got the idea pretty early on, they were willing to grab on to a different conceptualization?
There's definitely resistance to the diagnosis. For some people, it's right away, oh, now everything makes sense. This is why I had stomach pain when I was 8, and hip pain when I was 12, and headaches when I was 20, and now I have that. They get it. And for some people, it's really hard to wrap their minds around that. And what we found that can help there is if they do an activity like what we're seeing in the video here, and then experience a pain reduction in the moment, and they kind of have an aha moment, something whoa, I started thinking differently, and I saw my pain go down, and that's then presented to them as evidence that there's a lot of mind and brain processes that are involved here, because nothing we did changed your neck or your back. This is just changing what you're thinking about and relating to your pain. But I would say that kind of resistance to the diagnosis or the education is one of the main barriers. People have a hard time. The pain feels so real. How could this be true? Yeah, so that's and it's actually, in our experience, the invalidation is not people don't tend to feel as invalidated as just be just disagree. But I hear what you're saying, but I just don't think that's me. I get that could happen, but I don't think it's me. Yeah, but this is clearly a one sample, and super important to test this in other samples and see how other patient groups would respond to these kind of messages. and I'll return to that in my future directions. Okay, so last week, average pain intensity was the primary outcome. This is a little different than some trials. Some psychological treatments, like as I said earlier, really try to target functioning or disability, and some target pain intensity. So this is not unique or special, but in PRT, pain intensity is what we're focused on, and we're trying to resolve that symptom. We follow patients for 1 year after treatment. In the usual care group, people started about a 4. They had a slight reduction that was largely maintained for a year. In the placebo group, we saw a significant placebo effect. You can see this crossover interaction here from pre to post treatment. It wasn't maintained at all follow-up time points. This is an effect size around 0.5. And then in the PRT group, we saw a large reduction in pain down to just over 1 out of 10. And that was largely maintained for a year post-treatment. To look at this data another way, whoops. Hold on. Sorry. So each dot here is a patient. And in the usual care group, some people got worse, some stayed the same, some got better. The placebo group looks a bit better. And in the PRT group, we observed that no one got worse, one person stayed the same, and everyone else had some improvement, including what really caught our eye was down here, a cluster of people who reported 100% reduction in pain. And let me just note here that I was very surprised by these outcomes. This is just not what I was expecting. I did not really expect to see this kind of a large reduction. Maybe I had hoped for it, but definitely struck me. And to look a bit more closely at this group of people that reported 100% pain reduction, we created a category we call pain-free or nearly pain-free. This is people reporting 0 or 1 out of 10 pain. And about 2/3 of people in the PRT group were pain-free or nearly pain-free at post-treatment, relative to less than 20% of controls. And 1 year out, 1 year after treatment ended, we still see about half are pain-free or nearly pain-free. And I'm going to show another little video just to kind of put a patient face on this, and to reflect on this point that Ian raised earlier about resolution. Like, can it really be resolved?
I can honestly say I have 0 back pain right now. It's drastically different. I think I was 7, 8, 9, when I came in.
18 years. And it never stopped hurting for 18 years. I don't have any. I'm pain free. It's amazing. I can't even believe I'm saying it, but it's true.
So, this data, suggests to me, just on this point of, can there be a complete, resolution of symptoms or a near complete resolution of symptoms? We, looking at secondary outcomes, we saw effects on, we saw increased this is PRT versus usual care, increased positive emotions, reduced negative affect and sleep, reductions in disability, and reductions in pain-related fear. A number of these effects are conventionally, in the range conventionally considered large, effect sizes greater than 1. And what we really wanted to focus in on is these pain-related beliefs. This is the Tampa scale of kinesiophobia, which has some really lovely items. Pain always means I've injured my body. I wouldn't have this much pain if there wasn't something potentially dangerous going on in my body. I'm afraid I might injure myself if I exercise. Right? My accident or problem has put my body at risk for the rest of my life. So these are the beliefs, exactly the beliefs that PRT aims to restructure, right, to change. And what we found was that the effects of PRT on pain intensity at 1 year was mediated statistically by reductions in these injury beliefs, these fear beliefs. And that, paralleling those mediation results, the pre to post treatment, reductions in the TSK11, in these pain beliefs was correlated with reductions in pain in the PRT group. That's the blue dots over here. And my last patient video, because she just says it so well.
So the pain now, when I do get some pain, back pain, I'm more like, bring it on, come on, bring it on. No, this is nothing, I'm not in any danger, I'm not afraid. If it stays, it stays. If it doesn't, great, but it doesn't intimidate me.
So there's some transient symptoms, here and there, some back pain, but there's zero fear of it. Even whatever, the opposite of fear, this kind of just like cheery approach, attitude, and a large reduction in pain. So one of the key ideas we think, and we have data that supports this change in attitude, is reattributing the causes of pain. So we asked people in their own words to tell us, what are the top 3 causes of pain in your mind? And at pre-treatment, people told us things like injury, also stress, sitting, activity levels, weight, age, falling. And at post-treatment, people told us factors that we didn't see at pre-treatment so much, like anxiety, neural pathways, fear. Now, people are thinking these are the causes of their pain. So to measure this, we had blind coders rate the extent to which each attribution was a mind-brain attribution or a structural, medical, biomechanical attribution of the cause of pain. And so a 0 here is a totally structural biomedical attribution. So what you see at pre-treatment, everyone, regardless of group, was heavily on the kind of structural biomedical pain attribution. And we saw large shifts toward this mind-brain attribution in the PRT group. People really started thinking differently about the causes of their pain. And the extent of that attribution shift correlated with a drop in pain from pre to post-treatment. So we're thinking of that, helping people reattribute the cause of their pain is a key thing that supports this fearless attitude. Checking the time, okay. So turning to the functional MRI results, we had this back pain evocation device we created. Previous neuroimaging studies relied mostly on spontaneous fluctuations in pain and in experimental pain inductions like thermal stimulations to the forearm. And so this aimed to clinically relevant back pain during functional imaging. And what we saw here was that people reported in the PRT group a drop in evoked pain. And we used this task as a localizer. And we found that these were the regions that tracked back pain, evoked back pain intensity. And we tested for treatment effects in those regions. And we saw reduced brain activity in 3 of these regions, the anterior prefrontal cortex, anterior mid-cingulate, and anterior insula for treatment versus control. Now, so 2 things. One, these reduced brain responses to evoked pain provides a sort of objectively measured correlate of reported pain reductions. And these brain regions are of interest in particular because lots of other research has found that they are involved in the construction of negative affect and in threat and fear appraisals. So the reduced activity in these brain regions is kind of consistent with this idea of a reduced threat appraisal. So these are not the regions that most directly track afferent input from the body, like thalamus or somatosensory cortex, but are these higher level regions involved in, broadly, making sense of afferent input and appraising its threat level. We took these regions showing a treatment effect and submitted them as seed regions to connectivity analyses. And what we found was increased connectivity to 4 different subregions of primary somatosensory cortex. And these are increases in connectivity. And this is interesting, and there are multiple possible interpretations of what this might mean. One possible interpretation is that this increased connectivity, indicates increased communication or increased synchrony between somatosensory cortex and these prefrontal regions. And so there might be more input of kind of these bottom-up processes reflected in somatosensory cortex in the construction of pain. So that would be consistent with this like mindfulness-based model where the pain or the pain experience is more congruent with what's actually happening in the body and less kind of like on loop, independent of what's happening in the body. Okay, so the key finding here in my mind is that psychological treatments targeting fear, avoidance, and pain attributions can resolve a portion of primary CBP cases. In our study, it was a substantial portion. And the prefrontal and somatosensory pathways may be neurobiological mechanisms. Some of the limitations. So a stronger control intervention would be better. the relationship between psychological treatments and placebo treatments is actually quite complex, and conceptually a lot of connection between hope and safety and psychotherapy and placebo. So it's not easy to tease apart what it would even, what this means, or how to think about that. Sorry if I'm being unclear, but I'm glad to talk more about that. Another key limitation, 89% white. And this is the low to moderate disability sample. Like I hit upon the education findings. Patients all had at least some college education. Many were employed, many were quite physically active as well. And so we need to test generalizability to a more severely impacted patient population. And the clinicians in the study were experts, definite experts in the treatment model. So some of the key future directions I want to explore are, one is generalizability for whom, for whom can this work? Ethnically diverse populations must be tested, as well as lower SES populations. I think, this thread that we've been talking about of, can this message be delivered? Are people receptive? And our experience in this study, the answer is yes. But that is, I think, becomes more and more important, or more and more, just a super important question to test in other populations, because there could be all kinds of cultural factors or that influence how a person would respond to this kind of message. And frankly, I don't know. It's unclear to me if the message would be harder, less likely to be accepted or not, but super important. I'm very keen on testing the scalability. Could we get similar results with non-expert clinicians? What about group formats, or even a self-guided format in some way? Can you get some similar results? And then, the mechanisms. So the mechanism I've really highlighted here, because that's the one we have the most data for in my mind, is fear of pain. We see these changes in pain attributions and this mediation by the Tampa scale of kinesiophobia. And I didn't present this here, but we also have qualitative data where we interviewed patients about their experience and what in their understanding was most important. And many of them also talked about changes in how they relate to their emotions or their trauma history. And what I would interpret as an overall less fear, kind of less being on high alert, putting less pressure on themselves, being less critical of themselves. It's promoting a general sense of safety. So future research will need to be guided by this theory, these hypotheses about what the mechanisms are, and see whether we can still engage these mechanisms in scalable interventions and in other populations. I am also very keen on testing this in other pain conditions. Our study was in back pain. One population of interest in particular that I thought we could discuss in this group is non-cardiac chest pain. I know a lot of the people here have expertise in this. It'd be, it's a area I've just started reading about, but my understanding is that about 50% of ED admissions for chest pain are considered to be non-cardiac, and the symptoms are often persistent, and that some of these same factors are believed to be at play. So could a PRT, could an intervention based on these similar principles and techniques be effective in that population? And I will close with just thanking the study team and the funders. It was a great group that made this come together. And thank you all for your attention.
Thank you, Yoni. That was a really nice presentation. I really loved how you kind of gave us the background so we could better understand what you did.
Right.
And anyone on the anyone that's a participant, if anybody has any questions, we're a small enough group that they could say the question out loud, or they can put them in the chat.
Yoni, thank you so much for the talk. It was really interesting. Dr. Conor beat me to the punch when asking about the question I was going to ask about, and that was about mechanistic pain. Can you describe a little bit more about the screening that the individuals had to go through before they were eligible for the study?
Yeah. So I think what you're asking, Taylor, is about how do we know if it's primary pain or not. So that was really where that happened was in the assessment. This is post-randomization. We did some, had some basic screening to try to enrich the sample, but that was followed like a 1 hour assessment. So some of the factors that we look at are so spatial presentation of symptoms. So our symptoms in multiple body locations that would indicate centralized pain. Is there a spatial spreading of symptoms? So it started in the shoulder and then it kind of went down the arm. So injuries don't travel, but changes in the brain and spinal cord and processing can cause spreading across dermatomes and other factors. If the pain seems to be highly contextually sensitive, for example, pain's much worse on weekdays and not really there on weekends. Gosh, you think you ate your job? Is that something to do with it? Right. So these kind of contextual factors. Courtney, nice to see you.
Yoni, it's so nice to see you. I loved your presentation.
Thank you. I saw your name earlier. I was like, I wonder if that's the Courtney Stevens I know. But now
yes, I saw. I had to attend this because I was so interested to hear an update on this work because I know you've been at this for a while.
Yeah.
And I was thinking about at the end your last point about how it's sort of you're thinking maybe there's some spreading of activation with how teaching people this sort of exposure and reframing intervention also seems to help them with emotion regulation. And that just makes a lot of inherent sense to me. So I was just sort of percolating on that point for a moment here.
Yeah. Yes. I have a lot of thoughts about that, but let me just check in with Taylor for a moment and I'll come to that. But I was just so happy to see you. I haven't seen you in years. Courtney and I went to grad school in the same program.
Mm-hmm.
Yeah. So Taylor, so those are some of the factors. We also had radiological findings pre-existing available in about half the sample, and those were reviewed. And then there was a median of 4 findings per patient, like stenosis or disc degeneration or something like that. And in all cases, they were assessed to be not causal of the pain because the symptoms just didn't match, or they were just very much in the normal range of what's expected. If there's a long history of different somatic symptoms, headache, stomachache, etc., that's a factor indicating centralized pain. If there is adverse childhood experiences. So a lot of times, a lot of these boxes start to get checked for a patient, and then our confidence grows that this is primary pain.
That's really interesting. Thanks for the answer. The reason I ask is when I worked at Boston Children for 2 years in a pain clinic, and I felt that we never did a good job of describing our sample and doing due diligence into what their pain condition, whether it was primary or secondary,
Yes.
and the type of pain, neuroplastic, nociceptive,
Right.
et cetera, et cetera.
Important. I think that's a big distinction of a lot of like other psychological treatments. They don't aim to take a stand on that. They will say, in general, the causes of pain are complex and multifactorial, which I totally agree with. And they'll sort of leave it at that without saying like, hey, and that being true, we think that these mind-brain processes are the primary contributor to your pain. We think there might be nothing wrong with your body. And so that's where we're going to go further. And that might be a really important piece. And we tell people why. So we'll say, look, your symptoms have spread. You've had a range of symptoms. There's a lot of research on adverse childhood experiences in pain, and you're reporting some of those. And so we give people evidence for why we're coming to that conclusion. And it's kind of like makes sense for a lot of people. They're like, yep, I get it. So not everyone. Of course, there's definitely resistance. And that yes, I don't want to minimize that. There's definitely resistance.
Thank you.
Yeah. Courtney, as to your point, I do think that as people learn to like regulate the pain and to be aware and to mindfully watch the pain or remind themselves that they're safe, we then often use those skills to work with like anxiety. Like, oh, so anxiety has a physical presentation as well. Mm-hmm. Can you pay attention to the tightness in the chest? Remind yourself that, oh, that's a sensation. You can be aware of that. You don't have to be afraid of it. And so there is this pretty direct kind of transfer that we often try to do of how we work with the pain and how we work with other physical sensations that are more like emotion related.
Mm-hmm. Yeah, I mean, it is a bit different, I think, in terms of the neurological pathways, but I mean, this is very similar to the kind of paradigm that I'm working with patients in clinic around craving. So folks who are kind of struggling with response to craving and sort of the sensation of craving, and like that is okay that it exists, and how you respond to it can be different from this sort of habitual way that you've gotten used to in the past. So it reminds me a lot of that.
Yes. Do you work with the physical somatic sensations associated with craving?
Mm-hmm. Mm-hmm.
Like feel the craving in your body, there's something in the chest or the stomach? Yeah.
Mm-hmm. Yeah. So, I mean, this sort of mindfulness-based behavioral exposure approach is really similar to the kind of work that I am doing with patients that I see in my clinic. And so it totally makes sense. And I love this work. I think it's so interesting, and how fascinating the effects are that you can get people to have such reduction in pain. I mean, that is just, it's really, really cool. Something I wanted to bring up. So in clinic for me, I see patients who might be going for bariatric surgery, or they may have other kind of metabolic health conditions that they're coming to see me for around behavior change. And something that I hear a lot is folks say, and this is not too different than what we hear in other kind of conditions like depression, but it's like, once I lose weight, then I'll be able to do more. And there is this kind of belief that that weight is imposing a significant amount of the pain experience. And so I have to lose the weight in order to be able to be more active. And I mean, that's not totally accurate necessarily, but I mean, I guess in some cases it could be. Yeah, but I see that as being sort of like, I have this thing that I need to fix, and then I'll be able to work on, or then I'll have less pain. And I just don't think that the data actually bear that out. I mean, losing weight does not necessarily reduce pain. So I'm trying to get people to think about it more in the context of how you describe is really interesting.
Yeah, thanks for that. Yeah, I need to like double check the literature, but I don't think there's a strong relationship between weight and pain. There's no, like, maybe except for like really severely obese people, there's no clear reason that being overweight should be painful.
Yeah, but that message is really like, the patients get that message from their providers all the time. It's sort of a manifestation of fat phobia, but it's something that, as a psychologist working with patients on behavior change, their belief in this barrier is something that comes up for me a lot in the context of pain and behavior.
Yeah, it seems like and you work to challenge that belief.
So anyway, this is just super interesting to think about when I approach them for this.
Thanks.
We're almost out of time here. I just wanted to say, well, first of all, it was a great talk. It's really excellent. I'm curious, and this is sort of to the side, but I'm curious to hear your thoughts. So there's a lot of focus, obviously, on the sort of belief affective mechanism underlying pain reduction here. It makes total sense. I'm an affective scientist. I believe in it. I think it's real. I'm also interested, there seems to be this revolution in pain right now, pain research relating to glial cells and inflammation, and that's happening simultaneously. It came out in the New York Times this month. I'm curious what you think, if to the extent there's any overlap at all, what do you think about those mechanisms and the sort of psychological mechanism?
Yeah, I'm really interested in that. I'm aware of one method, like using PET imaging to measure glial activation in humans, but last I checked, there was kind of unclear how well it actually measures glial function. So in humans, it's difficult to measure. I think what I really think is like, gosh, wouldn't it be amazing if there's like psychological treatments could like downregulate glial function? And like, who knows, maybe they can in some way, or maybe, another mechanism I didn't hit upon as much as I perhaps should have is re-engaging in physical activity. So one thing we do is try to help people re-engage, become more physically active, and then that could change the somatosensory input that's reaching the brain, and that might, have a, effect on glial activity as well. I'm really curious about the role of glia and how, psychological treatments can directly or indirectly through their effects on neuronal processes, like then, impact the glia. You know, in my mind, it's some of the glial, one frame for thinking about this, and it's like another kind of learning mechanism. It's like another way that the brain learns the pain by having these glial, you know, cells activated and then becoming pro-pain and these positive feedback loops. And so it's this kind of like, you know, learning conceptually like a learning mechanism. Yep. Thanks.
Yeah, I would agree with that. I'm Nancy Chai, I'm a primary care doc, and there's always this focus on sort of the biomedical explanation. And I do find it, I'm questioning the need to make pain that you are describing primary, because in the end, it's just one continuum and it's just one big pathway. And so is it easier to speak to patients and explain it in the arm of peripheral nociceptive versus central, rather than to say you actually have primary care pain? Because if you're going to work with the chest pain population, it's going to be very hard, because most of them do have, everybody has coronary disease as our technology gets better. And what you are going to run into are all the other clinicians that they are seeing who are going to tell them something else. And it's a very uncomfortable place. Ian and I we're primary care docs. We try to do some of this on our own CBT for chronic chest pain patients, but like Courtney was saying, there's a whole other world of other clinicians that they see, and it puts you in a very uncomfortable place, because some of them actually do have pretty impressive diseases, but on top of it, they have central pain. So it's better to, I feel like, to describe it as one continuum, glial, whatever, and rather than separating it out as a single entity.
Yeah, thanks for that fantastic question. So I have like two hats when I think about this. Like, one, as a scientist, I'm like, yes, it's a spectrum. Of course, it's not binary. And then as a clinician, when I communicate to patients, I find it can be really much more clear and effective to say, this is primary pain. There's nothing wrong in your body, or we really think there's nothing wrong in the body. And that, because that kind of clear, simple message can be, in my opinion, very helpful at reducing fear. Whereas when you kind of hedge and say, look, you're on a spectrum, we're not sure if there's something wrong in your body or not, what the contribution of that is, then what people might hear is like, oh no, pain means something wrong with me. And that's the danger in my mind of being more nuanced and the truth. So there's some kind of fine line to walk, where on one hand, of course, we want to be truthful and accurate. That's imperative. And we want to, you know, deliver the message in a way that's therapeutic and helpful and will reduce fear. And yes, they'll get conflicting messages from providers, like that one video clip I showed. This woman had been told her neurosurgeon should be paying the rest of her life. And yeah, a lot of these patients have all kinds of findings that have been told, you know, for years are the cause of their pain. So that is something that we deal with, these kind of conflicting messages.
In the ideal model, we all work together, and that you reach out to the cardiologist. I think Barsky at one point did a somatization study where he found out that he couldn't really treat these patients without like sending notes to the other doctors to say, please stop sending them to the ER and calling it bone on bone and that sort of thing.
Yes, I totally agree. Yeah, having everyone on board and, you know, will first increase the likelihood that we've got an accurate diagnosis that it really is primary or secondary. Like, we want to know that. And it'll give patients, you know, clear messages and help them be unafraid when you have, when appropriate.
I think we're a little bit past the hour, and I want to respect our time, but Yoni, thank you so much. This was such a great discussion. I loved how you opened it up for discussion as we went along and gave a chance for people to interact during the talk. The talk will be recorded. It will be available through the Roybal Center site. If you Google sort of Columbia Roybal Center, it'll come up, and also I think through SOBC. And so please let your colleagues who might have missed it know that the talk is available. And you know, big thanks again to Yoni for presenting today.
Yeah, thank you, Ian, for inviting me. Thank you, everyone, for the discussion. That was great. Great. Okay, take care. Courtney, fun to see you.
Yeah, you too, Yoni.
Where are you?
I'm at Dartmouth now.
You're at Dartmouth?
Mm-hmm.
You know that Tor is there?